I'm Surbi Sadana, Associate Professor of Medicine at Stanford University and the lead for the Myeloma Disease Focus Group in the Division of Cell Therapy. On behalf of my colleagues at the U.S. Myeloma Immunotherapy Consortium, I'm presenting the data that we shared at ASH on how to enhance the safety of Cilta-cel in patients with relapsed myeloma, and can we identify potentially modifiable risk factors, especially those associated with delayed neurotoxicity and non-relapse mortality. We know we saw outstanding data from the CARTITUDE-1 trial earlier this year, with 1 in 3 patients being alive and progression-free at 5 years, raising the hope for functional cure in these patients. But we also know that while we have a very effective tool in our toolbox, there are side effects that we are aware of and that we are becoming aware of with Cilta-cel. Earlier on, of course, is the cytokine release syndrome and neurotoxicity. But as some weeks go on and months, there are 2 concerning things: delayed neurotoxicity that include Parkinsonism and cranial nerve palsy, and colitis. And there's others like cytopenias and infections and other long-term risks, which can all contribute to patients having adverse outcomes. This is the incidence of delayed neurotoxicity and non-relapse mortality, which is defined as death not due to myeloma, but from other complications. And you can see here the Parkinsonism rate vary anywhere from 0.5 to 6%, and the non-relapse mortality has been around 5 to 10%. At the ASH meeting, our group also shared some data that was done at Stanford and a couple of other collaborating centers, again, part of the Immunotherapy Consortium, where we showed that when you look at CAR-T expansion measured directly through flow cytometry, it's much higher in patients who have delayed neurological toxicity. So it's the CAR-T, the offending cells are much higher here. You can see here on the right-hand side, because CAR-T measurement is not directly available in the clinic, in the hospital, at most centers, we looked at absolute lymphocyte count. So CAR-T cells are a type of lymphocyte cells. We looked at absolute lymphocyte count as a surrogate marker and found that, yes, they can be used as a good surrogate. And in patients who develop Parkinsonism, as shown in yellow, the absolute lymphocyte count just takes off compared to patients who don't develop any delayed neurotoxicities or those who develop other things like cranial nerve palsy, like a Bell's palsy. So in this study, our objectives were, can we identify modifiable risk factors, so before someone gets CAR-T, to decrease the risk of Parkinsonism and non-relapse mortality? And then in a larger cohort of over 700 patients, validate the association of absolute lymphocyte count, a test that's readily available every day at bedside, and find different thresholds to predict the risk of developing Parkinsonism. Ultimately, our goal is to facilitate the development of risk mitigation measures for toxicities with Cilta-cel, particularly decrease the risk of Parkinson's and non-relapse mortality. This is the study design. This was done under the U.S. Myeloma Immunotherapy Consortium, which I have the privilege of co-founding and co-leading, with 15 other centers. And we had 761 patients who had received Cilta-cel between 2022 and December 2024. Delayed neurotoxicity was defined as any neurotoxicity or neurological side effects except ICANS, such as, but not limited to, Parkinsonism, cranial nerve palsy, etc. And non-relapse mortality was defined as death due to any cause except myeloma progression. These are the baseline characteristics of our study population. The median age was 65 years, though the range varied from anywhere from as young as 30 to as old as 88. About 40% of our patients had high-risk cytogenetics, and a third of our patients had extramedullary disease, which is defined as true extramedullary disease. Majority of our patients were heavily pretreated with a median of 5 prior lines of therapy, but we had about 16% of patients, or 120 patients, who received Cilta-cel for earlier line of therapy, so 1 to 3 prior lines of therapy, as per the CARTITUDE-4 results. Bridging therapy, which is treatment between collecting the cells or apheresis and infusing the CAR-T cells, was given to 86% of patients. And I want you to pay attention here because this will become important in later slides. PR to bridging, or partial response to bridging, defined as more than 50% reduction in monoclonal protein or free light chain, was seen in a third of patients who got bridging therapy. This is the safety. And for cytokine release syndrome, ICANS, infections, we saw very, very similar data as what we've seen in our other real-world study that was published in Blood and in clinical trials. The median follow-up here was about 10 months, and the response rates were very high, over 90% response rate. And the one-year PFS estimate of 72%, so that's patients at 1 year who did not progress or die, was very similar to what we'd seen in our previous real-world study. So what happened to delayed neurotoxicity? 10% of patients in our cohort experienced delayed neurotoxicity, out of which the most severe one is Parkinsonism, and this was seen in 22 patients, or 2.9% of patients. The most common one was cranial nerve palsy, seen in 4.6% of patients. Some patients, of course, had more than one, and the median time to onset was 1 month. I think here is the learning point, and I think this is what we wanted everybody to take away from ASH. When we looked at the risk of Parkinsonism based on response to bridging therapy, which is a measure of bulk of tumor left at the time of CAR T, we saw significant differences. The risk of Parkinsonism was 10 times higher in patients who did not respond to bridging therapy. The absolute risk was 5% compared to 0.5% in patients who responded to bridging therapy. In other words, out of the 22 cases that we had of Parkinsonism, 21 patients had not responded to bridging therapy. The post-CAR T response rate was quite high in these patients, approaching over 90%. So it's not that these don't respond to CAR T. These patients respond excellently to CAR T, but because they have a lot of high tumor burden, perhaps that's stimulating high CAR T expansion that is causing higher risk of Parkinsonism in these patients. We then wanted to validate whether ALC, or absolute lymphocyte count expansion, high expansion, is seen in these patients who develop Parkinsonism, as we had seen in our previous study that was also presented at ASH. And here you can see here on the left-hand side in yellow, there were 22 patients who developed Parkinsonism, and their lymphocyte count just takes off, compared to the red, which is other delayed neurotoxicity, and blue, which is no delayed neurotoxicity. The highest ALC count here, as shown in the right-hand side, is much higher in these patients compared to the other two cohorts. The median, or average, ALC count in the first 30 days for these patients was over 5,000 compared to about 1,000 per microliter in patients who didn't develop Parkinsonism. We then looked at different thresholds of peak ALC count in the first month. Patients who had an ALC count of over 3,000, a surrogate for CAR T expansion, in the first month, had a risk of 12% of developing Parkinsonism compared to 1% if they did not. If we used a threshold of 2,500, the risk was 9%. So this shows now in repeated study, our previous study that was also presented at ASH, and this study, that a cutoff of 2,500 or 3,000 can identify a majority of patients who develop Parkinsonism subsequently. And this has been shown in other smaller data sets as well. We looked at multivariable analysis, and this peak ALC count and response to bridging were independent risk factors for the development of Parkinsonism, even when we accounted for many other things. Then moving on to non-relapse mortality, which is death due to any cause except myeloma progression. The one-year estimate in our cohort was 9%, which is sobering. And most of these deaths were due to infections. Again, raising the point that it's so important to be so vigilant for infections, to have infectious disease prophylaxis, IVIG, so we can still continue to improve on preventing infections in these patients. Again, a very important learning point. When we look at non-relapse mortality, I want to focus on the right-hand side. Amongst patients who received bridging therapy, non-relapse mortality was half that in patients who responded to bridging, so PR or better, compared to patients who did not respond to bridging therapy. And this also was an independent risk factor for non-relapse mortality. So response to bridging was independent of other risk factors that were also associated with non-relapse mortality, including being in poor fitness, having high-risk cytogenetics and being older. So to summarize the findings from this abstract, non-response to bridging was associated with 10 times the risk of Parkinsonism and higher non-relapse mortality with Cilta-cel. And therefore, the message that we need to take home with this is that effective tumor debulking with bridging therapy is critical to decrease the risk of Parkinsonism and decrease non-relapse mortality with Cilta-cel. Peak ALC was significantly higher in patients who developed Parkinsonism, with ALC of more than 3,000 associated with a 12% risk of Parkinsonism. And this ALC can serve as a biomarker to identify patients for preemptive interventions and risk mitigation measures to decrease the risk of Parkinsonism. And based on this data, we have initiated a study called Citadel for early intervention with Cilta-cel to mitigate delayed toxicities such as of Parkinsonism and colitis. And this study that's being coordinated out of Stanford is open at 4 centers, Fred Hutch, Stanford, Moffitt, and Emory, and will evaluate if these risk mitigation measures in patients getting standard of care CAR-T do decrease the risk of these outcomes and bad side effects. So with that, thank you for your attention. And I want to give a huge shout out to my colleagues in the U.S. Myeloma Immunotherapy Consortium. 4 years ago, I had the privilege of co-founding this consortium with Dr. Doris Hansen at Moffitt and Dr. Krina Patel at MD Anderson Cancer Center. And at this ASH meeting, we had 22 abstracts presented, 14 oral abstracts, and 8 poster abstracts. Really speaks to the collaborative power, the power of coming together to generate data that can improve patient outcomes and improve our knowledge very rapidly in this evolving area. So thank you very much for your attention.